Welcome, everyone. If you are joining us today, you are diving into a space where medical science meets some incredibly complex human anatomy.
Yeah, it really is a fascinating area.
It is, and we are embarking on a deep dive designed specifically for you, the learner,
Yeah,
someone who wants to understand not just the surface level facts, but the actual deep mechanical realities of the human body.
exactly. We want to get right down to the mechanics.
Right. So today's topic focuses on a very specific and honestly incredibly important clinical question. And that is, how do clinicians safely isolate and palpate the pubococcygeus muscle to identify localized myofascial contributions to entry pain?
And to answer that, we are pulling from a really robust stack of sources. I mean, we've got clinical guidelines, some very advanced gynecology texts, and specialized physiotherapy protocols.
Yeah, a lot of heavy reading for this one.
Oh, definitely. We're looking at literature from the POGP Journal, the American Family Physician, and these really detailed clinical manuals that basically teach practitioners how to navigate the pelvic floor.
Which is so needed, because the mission for this deep dive is to demystify this highly specific and, frankly, often misunderstood clinical exam.
It really is misunderstood, yeah.
We are breaking down exactly how a practitioner finds this hidden muscle in the dark, basically, and figures out if it's the culprit behind chronic entry pain. So, okay, let's unpack this.
Let's do it.
Yeah, usually when we talk about a medical diagnosis, there is this expectation of precision, like engineering.
Right, like a clear structural issue.
Exactly. You break your arm, the X-ray shows that jagged white line, and the doctor just points and said, there it is.
Yeah, simple cause and effect.
But for a lot of patients dealing with chronic entry pain, which is clinically known as dyspareunia, there is no jagged line on an X-ray. For a lot of people, trying to achieve penetration feels like, hitting an insurmountable physical wall.
And we really should acknowledge just how isolating that experience is for a patient, because they are encountering this physical barrier, a wall of severe pain, yet on a surface level, an external exam might show that everything looks, completely normal.
Right, like nothing is wrong at all.
Exactly. There is no visible injury. There's no obvious structural anomaly on a standard scan. So the patient is left wondering if something is fundamentally broken that simply cannot be seen.
Structurally, though, when you actually dive into the mechanics of the pelvic floor, that wall often comes down to a tiny, angry knot in a very specific muscle.
Yeah. It's so localized.
It's acting like a stubborn bouncer at a club, just absolutely refusing to let anyone in.
That is a great way to put it, a stubborn bouncer.
Right. But before a clinician can even begin to examine that bouncer, they have to understand exactly what they're looking for and, honestly, establish a perfectly safe environment to even access it. So let's start with the target itself. Where are we actually going when we talk about the pubococcygeus muscle?
Well, we have to move past the idea that the pelvic floor is just a single sheet of tissue. It is a highly complex, multi-layered hammock of muscle.
Okay, a hammock.
Yeah. And the pubococcygeus is a major component of the deep levator ani muscle group. You can picture this as the third deepest layer of the pelvic floor musculature.
So it's way in there.
It is. And its normal everyday job is crucial. It helps support the heavy pelvic organs, like the bladder and uterus, and it maintains continence.
Right, keeping everything where it belongs.
Exactly. But when this specific muscle becomes hypertonic, meaning it's chronically overactive and just carrying a massive amount of excess tension, it initiates a powerful guarding response.
A guarding response.
Yeah, the muscle essentially locks down and creates a rigid barrier, making penetration incredibly painful, if not just completely impossible.
Wow. And because it's located in that third deepest layer, you can't just look at it with a speculum. You have to literally feel for it.
You do. It's an entirely tactile process.
But I was looking at our sources, and they make it very, very clear that a clinician cannot just jump straight into an internal exam. The clinical prep is incredibly specific and rigid.
Oh, absolutely. The setup is everything.
Yeah, the patient has to be totally, completely relaxed. And the texts mention putting the patient in a hook-lying position. That means laying supine on their back with the knees bent and ankles hip-width apart. Or, alternatively, they emphasize a very specific side-lying position.
Yeah, the side-lying position is specifically noted in the literature for deep targeted palpation.
Oh, really? Why that specific position?
Well, think about the biomechanics required to achieve true relaxation. The patient lies on their side with their top leg bent at about 60 to 80 degrees of hip flexion.
Okay.
And the clinician doesn't just have them hold their leg there, they actually wedge 2 or 3 pillows between the knees.
2 or 3 pillows, that seems like a lot.
It does, but this provides absolute stability in a neutral pelvic alignment. The entire goal is to remove any need for the patient's body to actively support that limb.
Oh, I see. So the physical setup of the clinician is just as precise too, right? I mean, they are washing their hands, they're using sterile gloves, and applying a very specific type of lubricant.
Yes, that is a huge factor.
The sources say it must be a low osmolarity, pH-balanced lubricant. Looking at this whole process, it honestly feels like entering a highly secure vault.
That's a perfect analogy.
Right, you don't just kick the door down, you need the exact right combination of relaxation, positioning, and specialized lube so you don't irritate the vaginal epithelium, the tissue line.
Exactly, you have to be so careful.
Which brings me to a question for you. I mean, I understand the sterile gloves, obviously, but why is the specific chemical makeup of the lube and the exact patient positioning so absolutely critical before a finger even makes contact?
What's fascinating here is that the pelvic floor is hardwired by our evolutionary biology for protection. It is a highly reactive, completely autonomous alarm system designed to respond to perceived threats.
An alarm system. Okay, that makes sense.
Right. So put yourself in the patient's shoes for a moment. If your posture requires you to engage your core or even your hip muscles just to stay stable on the exam table, the pelvic floor will naturally co-contract.
It tenses up to help balance the body.
Yes, exactly. And furthermore, if the clinician uses a standard lubricant that isn't pH balanced or isn't low osmolarity, it can actually cause a subtle or sometimes severe burning or irritation to those delicate vaginal mucosal tissues.
I see where this is going. If the tissue feels a chemical burn, the muscle underneath is going to flinch.
Precisely. The autonomous nervous system just takes over. The pelvic floor will involuntarily guard against that localized irritation.
Oh, no.
And once that flinch happens, the baseline tone of the muscle is completely destroyed.
Because it's already tense before you even touch it.
Exactly. The clinician is now trying to evaluate a moving target. They won't be able to tell if the pubococcygeus is tight because of a chronic underlying dysfunction, or if it is just tight because the exam itself is chemically or physically uncomfortable.
Well, you're getting a false reading, basically.
Exactly. Sneaking past that initial alarm system is quite literally the only way to make the rest of the assessment viable.
You have to bypass the security system without tripping a single wire.
That's exactly it.
Okay, so let's say the environment is perfect. The patient is fully supported by the pillows, completely relaxed, the correct low osmolarity lube is used. How does the clinician actually find the pubococcygeus? Because they are operating in complete darkness, using only their sense of touch.
It is a purely tactile navigation. It requires a highly refined internal map.
Right.
After obtaining ongoing consent, of course, the clinician gently inserts one lubricated index finger past the superficial layers of the pelvic floor.
How deep are we talking?
We are talking about going about 1 to 2 knuckles deep. Anatomically, that means inserting up to the proximal interphalangeal joint, which is your middle knuckle, or sometimes to the metacarpophalangeal joint, the base knuckle.
Okay, so pretty far in.
It varies, depending on the specific patient's internal anatomy and, honestly, the length of the examiner's finger.
Makes sense. Now, once they're past those superficial layers, our sources describe them using a mental clock face to map the area.
Yes, the clock face is standard.
Right, so 12 o'clock is straight up at the pubic bone, the pubic symphysis.
Yeah.
And 6 o'clock is straight down toward the anus and the perineal body.
But I have to stop here because I noticed a major discrepancy in the clinical guidelines when I was reading through the stack.
Oh. What stood out to you?
Well, one text says that to find the anterior fibers of the pubococcygeus muscle, the clinician should look at 5 and 7 o'clock, and for the posterior fibers, they look at 4 and 8 o'clock.
Okay, yep.
But then I turn the page to a totally different advanced protocol, and it says the levator ani, which includes the PC muscle, is located between 7 and 11 o'clock on the patient's left side and between 1 and 5 o'clock on the patient's right side.
Ah, I see.
Those numbers completely contradict each other.
Yeah.
Is this just a messy, inaccurate anatomical map, or are these texts describing something else entirely? That is a brilliant observation, and it is famously a massive point of confusion for medical students when they're first learning this anatomy.
I can imagine.
It is not a messy map at all, actually. You are looking at instructions for two completely different planes of spatial orientation.
Two different planes.
Yeah, we have to remember that the pelvic floor isn't a flat, two-dimensional circle painted on a wall. It is a three-dimensional curved bowl inside the pelvis.
Wait, okay, let me make sure I'm picturing this correctly.
Yeah.
Because I was thinking about a teacup. If I'm holding a teacup vertically in front of me, the opening facing me is the vertical clock, right?
Right.
But as my finger goes inside the cup and I tilt it backward, I'm now scraping the curved sides of the cup. Is that why the numbers shift?
That is a perfect analogy. Yes, when the finger first enters the vaginal opening, the clinician is operating on that vertical clock face, just like looking straight at the opening of your teacup. In that vertical plane, when they feel for the pubococcygeus attaching down near the pubic bone, they are feeling those fibers at 5 and 7 o'clock, with the posterior fibers at 4 and 8.
Got it.
But as the finger moves deeper into the pelvic cavity past those first couple of centimeters, the physical orientation of the muscles changes. They wrap around the pelvic walls. So the clinician must shift their mental map to a horizontal clock face.
So the clock literally tilts backward and lays flat inside the body.
Yes, exactly. Deep inside, on that horizontal plane, the pubococcygeus and the rest of the deep levator ani group span the lateral or side walls of the pelvis.
Okay, that makes so much sense now.
So to isolate the PCM muscle on this deep horizontal clock, the clinician turns the pad of their finger up toward the pubic bone to feel the anterior fibers near the midline.
Right.
And then they sweep laterally out to the side and downward. On that deeper horizontal sweep along the walls of your teacup, the muscle belly spans from 7 to 11 o'clock on the left side of the pelvis and 1 to 5 o'clock on the right.
That is just wild to me. The numbers change because the finger is essentially tracing the 3D curve of the bowl, moving from the rim down into the basin.
Exactly. You're mapping a 3D space.
If you are listening to this and trying to visualize it, just imagine your finger curving around the inside of a sphere rather than pointing at a flat wall on a clock. Okay, so we've navigated the 3D bowl. We have successfully located this hidden pubococcygeus muscle. Now, what are we actually feeling for?
Well, we're looking for dysfunction.
Right, but what distinguishes a normal, healthy muscle from the rogue bouncer that's causing severe entry pain?
It all comes down to the texture of the tissue, the resting tone, and honestly, the patient's response to targeted pressure.
Targeted pressure, how much pressure?
The technique dictates that the clinician applies mild to moderate pressure. And specifically, the guidelines mandate no more than 2 kilograms of pressure. They gently sweep the pad of their index finger along the length of the muscle fibers.
2 kilograms. Let's contextualize that for a second, because that is not a lot of force. That is roughly the weight of a standard bag of flour, but all of that weight is focused entirely on the surface area of a single fingertip.
Right. It is a very deliberate, intentional pressure.
Mm-hmm.
A normal, healthy pelvic floor muscle will feel soft and yielding to that bag of flour pressure.
Yielding, okay.
The patient will definitely feel the sensation of the finger, and they will feel the pressure, but it should not register as painful. It simply feels like an internal touch.
But if the muscle is abnormal, the sources use this incredibly vivid imagery. They describe finding a taut band that feels exactly like a guitar string running right through the muscle belly.
The guitar string analogy is foundational in pelvic physiotherapy. It's so accurate.
Why does it feel like that?
To understand why it feels like that, we have to look at what is happening at a cellular level. When the pubococcygeus is locked in a state of chronic guarding, the muscle fibers actually bunch up. And because they are constantly contracted, blood flow is severely restricted. The tissue becomes deprived of oxygen, and metabolic waste builds up inside.
That sounds painful.
It is. The protein filaments inside the muscle that are supposed to slide past each other smoothly, they essentially lock together like Velcro that just refuses to let go.
Wow, like Velcro.
Yeah, the tissue becomes fibrotic. So instead of feeling like soft, pliable meat, it literally feels like you are strumming a tight, inflexible cord.
And along that rigid guitar string, the clinician is sweeping for trigger points, right? Myofascial trigger points, or MTRPs, as the clinical texts call them.
Correct. These trigger points are palpable, hypersensitive nodules trapped within that taut band of Velcro-locked tissue.
And what happens when they press on them?
When the clinician presses on one of these trigger points with that 2 kilograms of pressure, it often reproduces the exact localized entry pain the patient experiences during intercourse.
See, here's where it gets really interesting to me. I think anyone listening can relate to getting a painful knot in their neck or shoulder, from staring at a laptop too long.
Oh, absolutely.
You press it, it hurts, and you know immediately, okay, it's a muscle knot. But I'm looking at these sources, and I am honestly a bit confused by one part.
What's that?
How does a muscle knot in the pelvic floor cause a patient to feel a burning sensation in their urethra? I mean, those seem like two completely different biological systems.
It is a masterclass in anatomical disguise, honestly, and it has everything to do with the complex wiring of the pelvis.
Wiring, okay.
Think about the pudendal nerve. It's the primary nerve of the pelvic floor. You can picture it as a thick electrical cable that threads right through these muscles, navigating through these tight canyons of tissue.
Okay, a thick cable.
When the pubococcygeus becomes hypertonic, when it swells and locks into that guitar string state, the canyon closes. The muscle physically clamps down on that pudendal nerve cable.
Ah, so the electrical signal gets pinched and distorted.
Exactly. The nerve compression alters the signals being sent back up to the brain. The brain doesn't just register an ache in the muscle, it registers burning, neuropathic pain. And it often refers that pain along the nerve pathway directly to the bladder or the urethra.
So consider the typical patient journey here. A patient goes to their primary care doctor complaining of severe burning, constant urinary frequency, and sharp pain with penetration.
Right.
Let's pause there because this is a huge realization for me. The doctor hears burning and frequency and immediately says, oh, you have a urinary tract infection.
Or perhaps they diagnose them with a mysterious inflammatory condition like vulvodynia.
Right.
This happens constantly. The patient is put on round after round of chemical antibiotics for a suspected bacterial UTI. Or they are given these topical creams for inflammation. Meanwhile, the actual root cause is entirely mechanical.
It's mechanical.
Yes, it is a myofascial trigger point in the pubococcygeus physically pinching a nerve and referring pain to the urinary tract.
That is just staggering to me.
Mm-hmm.
A structural mechanical issue is routinely misdiagnosed as a chemical infection,
Yeah.
which means the patient undergoes treatments that will literally never, ever work.
Never. Because you can't treat a physical knot with an antibiotic.
Exactly.
Yay.
This is why isolating and palpating this specific muscle with that 2 kilograms of pressure is so vital. If a clinician presses that hidden muscle and the patient says, yes, that is exactly the burning I feel in my urethra, they have just solved a massive clinical mystery that antibiotics could never fix.
It shifts the entire treatment paradigm from chemical to mechanical.
Right.
But, locating the muscle, strumming the guitar string, and finding the trigger points, that's still only evaluating the anatomy at rest.
Writing down, yeah.
Palpating a static muscle is really only half the battle. Because the pubococcygeus is a sling muscle, its ability to move dynamically, to contract, and most importantly to yield, is crucial to comfortable entry.
Which brings us to the next phase of the exam, right? A static assessment tells us about resting tone, but muscles are designed to move.
They are.
We need to know how the brain and the nervous system are communicating with that bouncer in real time. This is where the dynamic assessment comes in.
Yes. We need to see the software in action, not just the hardware.
Okay, the software, how do they test that?
While the clinician's finger is still resting gently on the muscle, they ask the patient to perform specific motor commands. First, they ask for a voluntary contraction, which is commonly known as a Kegel.
Right. Everyone's heard of a Kegel.
The clinician wants to feel the muscle physically squeeze around the digit, lift upward toward the head, and then, crucially, they want to feel the muscle let go.
I imagine that letting go phase is where a lot of the hidden dysfunction reveals itself.
Oh, it is the most telling part of the contraction test. A healthy pubococcygeus will generate a strong, controlled squeeze and then noticeably lengthen, softening all the way back down to its relaxed baseline. It fully releases its grip.
What if it doesn't?
Well, then comes the second part of the dynamic test, which honestly seems to be the most revealing for patients suffering from entry pain. The clinician asks the patient to perform a Valsalva maneuver.
Okay, for those listening, bearing down in a Valsalva maneuver is like mimicking the pressure of trying to have a bowel movement.
Yeah. Yes.
It is the body's natural physiological mechanism for pushing outward and relaxing the pelvic opening.
Think about the mechanics of bearing down. When a patient with a healthy pelvic floor performs a Valsalva, The clinician will actually feel physical space open up around their finger.
It opens up.
Yeah, the pelvic muscles lengthen, they descend slightly, and the entrance physically widens to allow passage. This yielding is the absolute physiological requirement for pain-free penetration. The doorway has to open.
But in a patient with a hypertonic PC muscle, our clinical sources describe something called paradoxical contraction.
Mm.
The bouncer isn't just refusing to open the door, they're actively pushing back.
It is a deeply frustrating phenomenon for the patient. A paradoxical contraction is exactly what it sounds like.
The opposite of what should happen.
Exactly. When the patient consciously, intentionally tries to relax or actively bears down to open the pelvic floor, the muscle does the exact opposite. It tightens, it lifts, it aggressively squeezes the examiner's finger instead of yielding space.
The brain is actively sending the command, open the doors, and the localized muscle is intercepting that signal and saying, absolutely not, we are on lockdown.
Yeah.
Why does the brain fail to override that?
If we connect this to the bigger picture, it explains the true nature of dyspareunia. The brain isn't failing to send the signal. The localized neuromuscular junction is overriding it.
Wow.
Myofascial entry pain isn't just a structural abnormality where a muscle is like a little tight from a workout. It is a severe neuromuscular control issue. The muscle is caught in a closed loop of hypervigilant guarding.
Hypervigilant.
Yes.
Right.
The local nervous system perceives penetration as such a high-level threat that it just refuses to accept the relax command from the central nervous system.
It's a software glitch driven by a protective reflex. I mean, the patient is not doing this on purpose. They want to relax.
Absolutely not on purpose, no.
But because that rogue muscle forcefully contracts precisely when it's supposed to yield, any attempt at penetration hits a literal physical wall of localized muscle tissue.
Which perfectly explains why the patient experiences an insurmountable barrier, even when they are completely relaxed everywhere else in their body.
So what does this all mean? We started this deep dive talking about the isolating feeling of an invisible, insurmountable wall. And look at the incredible journey we just took to uncover it.
It is a journey.
We learned how clinicians have to meticulously set up a perfectly safe, non-threatening environment, using pillows for neutral alignment and precise pH-balanced lubricants, just to sneak past the body's autonomous alarm system.
Right.
We saw how they use a complex 3D internal clock to navigate past the superficial layers, shifting from a vertical teacup rim to a horizontal bowl just to isolate the deep Pubococcygeus muscle.
Mapping that whole space.
Exactly. We explored how they gently strum it, using the focused 2-kilogram weight of a bag of flour, to find those hidden, oxygen-deprived trigger points that pinch the pudendal nerve and masquerade as incurable UTIs.
Yeah, that's such a key takeaway.
And finally, we saw how testing its dynamic movement reveals a rogue muscle that paradoxically contracts when it should relax, completely overriding the brain's own commands. For you, the listener, understanding this hyper-specific, step-by-step process does something incredibly important.
It does.
It completely demystifies these vulnerable pelvic exams. More than that, it proves with absolute certainty that chronic entry pain isn't just all in someone's head.
Not at all.
It is a highly localized, physically palpable muscular issue. It is a real, mechanical, and neurological problem that can be objectively mapped, felt, and ultimately treated.
It absolutely can be treated through targeted physical therapy and neuromuscular reeducation, which is honestly the deeply hopeful takeaway from all this clinical data.
It really is hopeful.
But understanding this mechanism leaves us with a really fascinating question to ponder. Think about the sheer, uncompromising power of that guarding reflex.
Oh, yeah.
If a tiny muscle hidden deep inside the pelvis can become so hypervigilant that it involuntarily locks up, acting as a physical barrier despite the patient's conscious, active desires to relax, what does that tell us about the profound, unseen ways our nervous system stores physical protection?
That is a great question.
And if the human body can learn to guard a space this fiercely against perceived threats, how much care and how much incredible neuroplasticity is required to finally teach that body that it is safe to let go?